Hello class, this is Chris Frigno. This is my first recording, so please bear with me. Today I will talk to you about the posterior shoulder, the shoulder joint, and the associated shoulder musculature. Why do we want to learn about the shoulder? Well, in my personal practice, about a third of my patients, anywhere from 25 to 30 to 35%, were suffering from some sort of shoulder pain, usually associated with a rotator cuff injury. As we see here, the shoulder pain is reported to be the third most common musculoskeletal disorder after neck pain and low back pain, and this was quite consistent with my practice as well. When you hear rotator cuff, as we move forward in the musculature, you want to associate rotator cuff with the supraspinatus tendon, especially as it relates to dysfunction or shoulder pain. Most of the time when I saw someone with rotator cuff pain, it was specifically targeting the actual injury was within the supraspinatus tendon or around that tendon. Also note that we have conditions in the shoulder that are coined bursitis. So bursa are small fluid-filled sacs. They are situated between usually one moving element to a stationary element, or a relatively stationary element, sometimes between two moving elements, usually in the form of two tendons. But these bursa can get inflamed with repetitive use, injuries, or during a one-time injury where one is falling on that area. So this should be a review for you guys. So we went over the trapezius last week, the latissimus dorsi, okay, the levator, and the rhomboid, minor and major. If I were to ask you what muscle within this group attaches, or I should say which muscles attach to the arm directly, you would be right if you had said just the latissimus dorsi. All the others, including good old large trapezius, connect in with the shoulder blade, or otherwise known as the scapula, or the clavicle, or both. So let's move on to some new structures. If we look down here on the bottom picture, we have a review in black writing of the structures you're familiar with associated with the scapula. We have the superior angle. If we have a superior angle, we must have an inferior angle. We have a medial border, and if you have a medial border, you must have a lateral border. We've already seen the spine of the scapula. Now look here, the spine goes or extends from that medial border all the way up to the acromion, all of which is the spine of the scapula. If you remember, what is this demarcation zone? Well, this is rhomboid major to rhomboid minor. What's above rhomboid minor? Up in this area, extending out that way, would be levator scapula. Now we have in blue, here we have a couple other structures I guess I should review as well. We have the acromion and the glenoid fossa. Okay, and we'll see especially the glenoid in just a little bit in more detail. Some new structures associated with the scapula we'll start over here. Okay, we have the supraspinous fossa. The supraspinous, which means supra meaning above, spine meaning the spine of the scapula. So we have this area roughly is the supraspinous fossa. And then of course we have the infraspinous fossa. So we have this area down in here. It is below the spine of the scapula. Okay, moving superiorly up in this area, we have the suprascapular notch. So this notch is this void in the superior border of the scapula. And we'll soon see that there is a structure that spans that void, and we'll talk about that in a minute. So we have the suprascapular notch, and that's this area that I just spoke of. And then over here we have the greater scapular notch. Now I'm going to try to draw this in, but it's in this area, and it's as the scapular spine extends outward, it becomes somewhat detached from the body of the scapula, and so this is almost a partial tunnel up underneath the lateral spine of the scapula, or the beginning of the acromion process. Now, keep in mind the structures we just saw on the previous page, we're looking at the scapula posteriorly, so it was a posterior view of the scapula. Here on the top segment of this slide, we have an anterior view of the scapula. So again, since we're on an anterior view, we still see the superior angle. We still see a medial and a lateral border, and we still see an inferior angle. But now what we don't see, for the most part at least, is the spine of the scapula, because that's behind the main body of the scapula. But what we now see is this very large subscapular fossa. So the whole fossa, this is kind of outlining roughly the subscapular fossa. And within that fossa, we'll have a very large muscle that we'll see later, but that's called the subscapularis muscle. Again, laterally at the top of this lateral border, we have this infraglenoid tubercle. So roughly there. Well, you have an infraglenoid tubercle, you're probably going to have a supraglenoid tubercle. Now that's not labeled here because it's obscured by this process called the coracoid process. So all this structure here is a coracoid process. But if we were to look just posterior to the tip of the coracoid, up just above this arch here of the glenoid fossa, we would see something similar to the infraglenoid tubercle. It's called the supraglenoid tubercle. So I would like you guys to know that as well. So I'm going to write that in, the supraglenoid tubercle. Okay. All right, let's move on to the humerus. So here we're looking at an anterior lateral view, okay, of the humerus. So the very proximal end of the humerus is called the head of the humerus. So here we see the head of the humerus, and the illustrator here is showing the head of the humerus covered in cartilage. Can anybody remember what kind of cartilage covers the end of a joint? It's called hyaline cartilage. Okay. The humerus has a very short but robust anatomical neck, or just the neck of the humerus. Okay. So that's going to connect in the main shaft of the humerus, to the head of the humerus. Now we have two necks. So we have this anatomical neck right up in there, and then we have this surgical neck right in here. You can imagine why that might be called a surgical neck, because a lot of surgical procedures are addressing that portion of the neck. So again, just a transition zone between this proximal large ball segment to the shaft of the humerus. Okay, far lateral, you have this huge process or bump, or what we call tubercle, on the outside of the humerus, and that's called the greater tubercle. In between we have this groove. I'll color the groove in. And medial to the groove we have a lesser tubercle. Okay, so we have a greater tubercle laterally and a lesser tubercle medially. So what are tubercles? Well, anytime you see an outcropping or a rough area of bone, that's going to be an area where muscles love to attach, or other soft tissue structures love to attach. So here we have a greater tubercle that we're going to see quite a few structures attached to, and then a lesser tubercle we're going to see one primary structure attached to. Now, I've already obscured it with my pen, unfortunately, but we also have more distally here. We have a lateral and medial lip and the floor of this intertubercular sulcus. Okay, here we have it, the label, and the sulcus, like I said, is obscured. I'm going to kind of draw it in there. Okay, that's the sulcus. Okay, and as the script says here, it says these are landmarks for the insertion of several important muscles, one of which, the latissimus dorsi, you've already seen. And so this is medial. So that latissimus came from behind, and I'm sorry I can't draw perspective here, came from behind though and attaches up into or close to this intertubercular sulcus. And you see how rough this area of bone is as compared to maybe this part is very clean. Further down, I'm going to kind of highlight the region here, we have this deltoid tuberosity. What do you think might attach to the deltoid tuberosity? Well, I think that's quite clear. Let's move on. So I mentioned last week that the appendicular skeleton has a single connection to the axial skeleton. So that's the appendicular skeleton, or the skeleton of the arms and the legs, have a single connection, at least in the upper extremity, to the axial skeleton via the scapula, then attached to the clavicle. Here we see the clavicle coming in, where it attaches to the sternum. So this is an important joint because as we raise our arm up, or as we try to move our arm around, we get motion here at the sternoclavicular joint. Okay. This is also called, by the way, nicknamed just the SC joint. And as we go over here, we'll call the acromioclavicular joint the AC joint. And when we write GH joint, but we typically don't say that in the clinic. But we will say the SC or AC joint in the clinic. So here we have the SC joint. This is a very strong joint, extremely strong, and a couple key features, okay, that we see. I think we might see actually on a subsequent slide, so I think I'll reserve that here for now. Then we have the AC joint here, or the acromioclavicular joint, where the clavicle meets the acromion, and then of course we have this glenoid or glenohumeral joint. That's just kind of an overview. So let's take a look, and we'll kind of look at the lateral structures first, and then we'll move more medially. So here on the bottom left panel, we have an glenohumeral joint and an acromioclavicular joint with some of the key, sometimes strong, sometimes not so strong, soft tissue structures. For instance, we have the clavicle here, and we have the acromion here. And where they meet, of course, we have a acromioclavicular ligament, and that's spanning across here. But when the acromion ends anteriorly, it needs to connect up with this process called the coracoid process. So we have this very strong soft tissue structure called the coracoacromial ligament. Keep in mind that we will see a muscle, at least the tendon of the muscle, and maybe part of the muscle belly itself, spanning up underneath this bridge made by the coracoacromial ligament. And so the spacing between the bottom of the acromion and the top of the humerus, this spacing is very important, as is the spacing between the coracoacromial ligament and the top of the humerus or the top of the glenoid fossa. That spacing is also very important because of that muscle running up under there. That muscle, by the way, will be the supraspinatus muscle or the supraspinatus tendon. And so that becomes clinically very important. We also have a corticoclavicular ligament, so that connects the coracoid process to the clavicle. And so this really helps reinforce the distal end of the clavicle, because the AC ligament here is simply not enough. You can see how its fibers are oriented medial-lateral. It's simply not enough that if you fall, if you have a downward impact here or a downward impact here on the acromion or on the distal clavicle, you need some additional support. So both the corticoclavicular ligament, there's two parts. There's this part and this part. You won't have to know the name for that. Both those, along with this coracoacromial ligament, give big support to the acromioclavicular ligament. We also see in this panel are the three glenohumeral ligaments. We have the superior, the middle, and the inferior. And you can really make them out pretty well here. I'll maybe put a little dotted line for the superior. Do that for the middle. And do that for the inferior. So these, as you can see, give support anterior, but also superior for the superior one and inferior for the inferior one, and really just pure anterior for the middle one. Now, these aren't the most robust ligaments in the world. Interestingly, all three ligaments are positioned more on the anterior side of the glenohumeral joint, but the anterior direction is where the joint is weakest, as well as the inferior direction. So it's weakest anteriorly and inferiorly, despite these ligaments being there. So that's a clinically important thing to take home, that despite having the reinforced joint capsule that sits beneath it by these three ligaments, it's still very weak anteriorly. Note here on the right, bottom right panel, that drawn in red, we have the tendon of the long head of the bicep. Now this tendon, as you can see, runs in this intertubercular groove, also called the bicipital groove. And I want you to know that both of those names. So the tendon of the long head of the biceps, that'll become clearer in subsequent lectures. The tendon, the long head of the bicep, comes up into this groove. It runs under this transverse ligament of the humerus. Okay, and as it runs up, it goes over the top of the shoulder, in front of the supraspinatus tendon, and it inserts what we don't see here on that supraglenoid tubercle that we saw on a previous slide. All right. Now, despite having all these reinforcements here on the lateral side, many people develop what's called an AC, or an acromioclavicular joint separation. It's quite common. So you'll hear about shoulder separations. That's what we see here. That's typically associated with the AC joint. You also have shoulder dislocations. Now, shoulder dislocations are more pertinent to the glenohumeral joint, okay, more pertinent to the head of the humerus slipping out of the glenoid cavity fossa and not being seated properly anymore. But in the AC joint dislocation, many things can happen, specifically the corticoclavicular ligament and the acromioclavicular ligament can get detached. Now, keep in mind that other soft tissue structures may or may not be lesioned, okay? But as we've just recently learned, the trapezius attaches to the distal clavicle. So when you have the contraction of the trapezius during an event like this, you can get further separation. So it's nice to put the arm in a position where the trapezius is not having to be tensioned. So this is why that's the elbow. This is why we put them in a sling. It makes them feel much better because now the drop of the shoulder isn't so significant and is not pulling on this lesioned ligament. Okay, now more medially, like I promised, we are going to see some key features of the sternoclavicular joint. Okay, so down in this bottom left panel, we see that there's a sternoclavicular ligament. Yes, there's an anterior and posterior portion, but you should just know that there's a sternoclavicular ligament. Okay, it's very strong. It's very strong. Certainly, there's not a huge lever arm on this structure during injury, but it's very strong here. And also, this joint has what's called an articular disc, and this is a fibrocartilaginous disc that sits in between the clavicle and the sternum to help direct the gliding of the clavicle on the sternum. And so this joint, there will be plenty of motion in this joint, both in some elevation of the clavicle, but also rotation, especially rotation of the clavicle on the sternum. Lastly, on the slide, we see the glenoid labrum. What is the glenoid labrum? Well, here we see the glenoid labrum. It's on the outer edge of the glenoid cavity, scribbled in here. So we have this glenoid labrum. It's made up of fibrocartilage, and it sits on this outside of this glenoid cavity, and it deepens the socket, or it deepens that glenoid cavity. It provides a little bit more structure for the humeral head to rest into. Here we see labeled the long head of the bicep muscle. Note that this long head, as it's approaching the scapula to insert on the supraglenoid tubercle, it also has an attachment here at the top, or at the 12 o'clock portion of the glenoid labrum, prior to its attachment into that supraglenoid tubercle. So if you get a violent contraction of your biceps, let's say the classical example is you are outside and you see a fire in a building, and from 3 stories up, there's a crying mother who is going to take her baby and entrust you to catch her baby as she tosses the baby out of the window, and you catch this 10, 15-pound human. And you brace very hard because you want to protect this baby. And as the inertia comes, the baby arrives into your hands, and the contraction is so intense, and you have so much adrenaline at this time that you're capable of doing that. But in the process, you might lesion either the long head of your biceps tendon, or the labrum, the labral attachment might rupture off of the glenoid, the rim of the glenoid cavity. So that's a kind of a clinical scenario that at some point in time one sees, maybe not the baby part, but perhaps certainly a weightlifting injury or some other forceful contraction of the biceps. Now we sat here and have discussed all these ligamentous support structures, labral support structures for the glenohumeral joint. We discussed an anterior, middle, and inferior glenohumeral ligament. We have the labrum. We have the biceps tendon that crosses over there to give some support. So one would think that all these supportive structures makes the glenohumeral joint very stable. But as we know, things that want to be mobile, and we all certainly want our shoulders to be mobile, sacrifice something, and that something is stability. So our shoulder relies a lot also on muscular support, primarily in addition to that biceps tendon, we rely on our rotator cuff to support the glenohumeral joint. So here we are introducing the rotator cuff. And its primary role, again, is to help support the glenohumeral joint. It certainly also provides movement to the glenohumeral joint, and we'll discuss that in a minute as well. So as we see here, we have a supraspinatus, we have an infraspinatus, we have a teres minor, and a subscapularis. So it's nice, this view is very nice. I'll change my color, and this view is very nice to see that the supraspinatus really comes in at almost that 12 o'clock position. If we rotate around to the right, now we see the supraspinatus, the subscapularis coming in anteriorly at the, let's call it the 2 to 5 o'clock position. Then inferior and to the left here, at least on this right shoulder, we have the teres minor comes in on that 7 or 8 o'clock position, and then we have a much larger, compared to the teres minor, an infraspinatus. It comes in more at the 9 o'clock position. We're going to see these muscles a little bit more as we go ahead. What I also would like to point out are the non-rotator cuff muscles, and we see those up here and down in here. We're going to go into those a little bit more right now. So on the bottom picture, we have the picture that you should be quite familiar with. We also have much of this picture that you should be familiar with, at least that. Now we're going to add two more muscles, the deltoid and the teres major. Note that these are not rotator cuff muscles. Okay? These are not rotator cuff muscles. However, they do certainly act directly onto the glenohumeral joint. Okay. So from posteriorly, you see that this deltoid attaches to the spine of the scapula. I'm going to change my color again. Attaches to the spine of the scapula. It also attaches to the acromion, which we would see laterally, and then anteriorly, like the trapezius, it attaches to the lateral third of the clavicle. And here we see that deltoid, again, lateral third of the clavicle. We have the acromion process, and then we have the spine of the scapula. It's all going to come down to insert on what? Well, we saw it earlier when we talked about the humerus. It inserts onto the deltoid tuberosity. So it's this ridge of bone. We can see that. We'll see that on bone in the lab, where the deltoid attaches. And so what will this deltoid do? Certainly it has anterior fibers that can help to flex the arm. It has lateral fibers that can help abduct the arm. That's abduct. And it has posterior fibers that can help extend the arm. But typically the deltoid is known, if you had to assign one motion, it would be to abduct the arm. The innervation of deltoid, by the way, is the axillary nerve. It does also have a primary vascular supply called the posterior humeral circumflex artery. Moving on, we have what's called the teres major. Again, not a rotator cuff muscle. Here we see the teres minor, which is rotator cuff. But over here is teres major, which is not a rotator cuff muscle. It comes from the lateral border of the scapula and maybe a little bit of that inferior angle. And it attaches, again, anteriorly to the humerus. Now, this is a good time to talk about what this anterior on the humerus, and also, as you can see, it goes across the medial edge of the humerus. What does that mean functionally? Well, because it runs inside, and it does not loop around the humerus on the outside, when it contracts, not only is it a powerful adductor, but it can also internally rotate the humerus or medially rotate the humerus. Similarly, if we look from an anterior view, what is this muscle over here? This muscle also goes up into the armpit and goes medial anterior on the humerus along with teres minor. Not sure why I just crossed that out. I didn't mean to. Both of those together, as well as this broad muscle that we'll see soon, contribute to medial rotation of the humerus or internal rotation of the humerus at the shoulder. Okay. I should also say here that the innervation of teres major is the lower subscapular nerve. And we'll see that especially when we look at the brachial plexus next week, I believe. Now let's move back to the rotator cuff, and so here we see a posterior view. So posterior, we're going to see 3 of the 4 rotator cuff muscles. So we see the supraspinatus, the infraspinatus, and the teres minor. Note that again, the supraspinatus is above the scapular spine. The infraspinatus is below the scapular spine, and the teres minor is below infraspinatus. All of this being infraspinatus, all of that being infraspinatus. Okay, but this portion is teres minor. Sometimes a little harder to make out where one ends and where another begins in lab, but we'll clear that out when we get into lab. And here we see that teres major that we just spoke about down in here. So as you might imagine, that infraspinatus, when it contracts, it will pull on the greater tubercle of the humerus, and it'll pull it that way, which would be external rotation. Similarly, the teres minor will pull on the posterior aspect of that greater tubercle and externally rotate the humerus. Supraspinatus, as you can see, muscle belly being over here, dives underneath the acromion, that bridge of the acromion, and the coracoacromial ligament. And here we see a little bit of the muscle tissue and then tendon, and attaches again onto that greater tubercle. And when it contracts, it will bring the humerus outward or abduct or abduct the humerus at the glenohumeral joint. Note that a very large muscle, that deltoid, also abducts the humerus at the glenohumeral joint. However, the supraspinatus is thought to be primarily involved in the first 15 degrees of abduction. Certainly it'll help beyond that, but during the first 15 degrees, the deltoid doesn't have very much mechanical advantage to abduct. But the supraspinatus, because of this linear direction, certainly does have mechanical advantage to abduct during those first 15 degrees. Now we flip that shoulder around. We're still looking at a right shoulder, so this is an anterior view, and we see the 4th rotator cuff muscle, subscapularis. And so subscapularis originates from this subscapular fossa that we saw earlier, and again attaches medial, the lip that makes up the medial border of the intertubercular sulcus. So it attaches here as well. So when it contracts, it can do a couple things. Maybe if the arm was abducted at the time of contraction, it can adduct, but its primary role is to internally or medially rotate the humerus at the glenohumeral joint. Now in this picture we see the posterior view and we see the anterior view. So we get to see all four of these structures. We get to see their origins. I like this a lot, seeing where they generally originate from, and then their very specific insertion points. And then down here we can also summarize, look at their innervations and their primary actions. So note that the supraspinatus and infraspinatus are both innervated by the suprascapular nerve, and that comes from off the brachial plexus from the C5, C6 trunk, I should say, yeah, trunk. The teres minor also comes from a C5, C6 nerve called the axillary nerve, but that's off of generally off of the posterior cord. So we'll see that when we get into the brachial plexus next week. And the subscapularis is also C5, C6. I'm pointing this out because sometimes students say it's just too much to learn. But if you note, just about everything that controls the shoulder, including the deltoid, is C5, C6. And so, but the subscapularis is innervated by this upper and lower subscapular nerve. And all this will make more sense after we do the brachial plexus. Now that we've covered most of the muscles of the shoulder, I say most because there's still a few on the anterior side we haven't seen yet. But I wanted to take a moment to discuss some of the neurovasculature of these muscles. So on this top panel, we see this thing called the quadrangular space. Well, the space isn't so important as what structures run through them. But most of the time, students are required to memorize the borders of the quadrangular space. And I'm not so concerned about the borders as I am, again, about the contents. But I would like to go over the borders for so you can understand exactly where it is. So I'm going to highlight it here. Okay, so that's the quadrangular space. And here we see the teres minor. Here we see the teres major crossing underneath the long head of the triceps. And then we have the humerus. So those are the borders. Teres minor above, teres major below, long head medial, and the humerus lateral. But let's take a look down on the lower panel. We can see the contents of this quadrangular space. So here are the contents of the quadrangular space, specifically the axillary nerve and then the posterior circumflexhumeral artery and vein. We'll just talk about the artery. So the axillary nerve is responsible for two, and today we'll talk actually about a third structure. It's responsible for innervating the deltoid, also the teres minor. You see that teres minor innervation right there. But one of our research projects in the lab, specifically a graduate student of mine, is looking at the innervation of the long head of triceps by the axillary nerve, and we're finding that most long-headed triceps are innervated by the axillary nerve, although most of the textbooks suggest that the long-headed triceps are innervated by another nerve called the radial nerve, and we'll see that another time, but this illustration is showing it here. But I would like for you guys to know that all three of these muscles are usually innervated by the axillary nerve. Let's turn our attention a little northward here, and we have the suprascapular nerve. So the suprascapular nerve comes off the brachial plexus quite high, off of C5 and C6, and it traverses across the neck a bit, and it ends up in this area above the scapula. And you notice that the suprascapular nerve is traveling down, and it goes underneath the superior transverse scapular ligament. So the superior transverse scapular ligament is spanning across the suprascapular notch. Okay. The nerve goes underneath the notch while the suprascapular artery goes over the notch. So a little mnemonic for that is Army over the bridge, Navy, right? Navy goes under the bridge. That kind of makes sense, right? So the A in Army aligns with the A in artery, and the N in Navy aligns with the N in nerve. Great. So the suprascapular nerve ends up going underneath, choose another color, goes underneath and then innervates the supraspinatus, then goes around and underneath the greater scapular notch to innervate the infraspinatus. So in this picture, we actually see that suprascapular artery. It's coming off pretty high up off the subclavian. And then it traverses across the neck, and again, it goes over the transverse scapular ligament, the superior transverse scapular ligament, to serve supraspinatus, go around underneath into that greater scapular notch and serve the infraspinatus as well.
A few other important arterial features that we see here in the slide. Take a look over here. We see the posterior circumflex humeral artery. It's coming off much lower down here off the axillary artery to serve the upper humerus. It might also give off some muscular branches that serve muscles such as the teres minor, the long head of the triceps, other parts of the triceps as well. Even more important, we have this idea, if you will, of a scapular anastomosis. There's several arteries that contribute to the scapular anastomosis. We have the dorsal scapular artery. It originally potentially came off the transverse scapular, or transverse cervical artery, excuse me. We have the aforementioned suprascapular artery. And now we bring in this other one called the circumflex scapular artery. The circumflex scapular artery, you will learn, especially in the next lecture, that arises from the subscapular artery, again off the lateral third of the axillary artery. Here we see it coming off the lateral third of the axillary artery, coming around, getting off the circumflex scapular artery. So these arteries come together in this infraspinatus fossa and join in anastomosis. And this is important because imagine you have a lesion in your axillary artery, where I drew this X right here. If you have a lesion, in other words, let's say you have a huge blood clot in that artery, blood can take a circuitous route up the subclavian, up the transverse cervical artery, around the dorsal scapular artery, through this anastomosis, come out the circumflex scapular, up the subscapular, and then down to serve the arm. So this is an important functional anatomical relationship to understand.
That concludes this lecture. Please let me know if you have any concerns, maybe complaints, and also give me some feedback on the video to let me know if everything, if the audio was understandable, both from a volume point of view and if my annotations were okay as well.